Hello, everybody. Thank you very much for coming. And we're going to get started. This is our last lecture of the year. So it is a shocking conclusion. And looking back at everything that we've done so far, this is the, I think, appropriate end and culmination of all the other things that we've talked about. And I think hopefully by discussing how to use echo to approach undifferentiated shock, it'll become clear how everything we've talked about until now sort of feeds into this, which is probably the reason why many of us are picking up our probes in the middle of the unit. So without further ado, the goal for today is to discuss an approach to using critical care ultrasound for undifferentiated shock. There are some hidden goals, which are, as I already mentioned, to tie together all of this year's lectures. Also to take the opportunity to highlight some of the advantages of advanced critical care ultrasound and maybe also distinguish its importance from formal comprehensive echocardiography. And there are going to be some, I'm going to introduce the my 6-step approach to echo for shock, a very brief review of the basic windows, and then 4 clinical cases. So hopefully we'll have some chances to interact, and then we will finish up. And so the my 6-step approach to shock sort of starts with this. So we're all familiar with the common 4 buckets of shock, and there's obstructive shock and cardiogenic shock, and we're sort of taught to use this frame to think about all the different ways that all the different etiologies of shock. But the truth is that this framing is perhaps a little bit oversimplified and maybe undersimplified, because many of these conditions are treated differently, right? So a PE is not treated the same way as tamponade, is not treated the same way as a pneumothorax. So these categories don't imply a specific management. And some of these conditions actually cross different categories. So valvular disease can cause both an obstructive shock and a cardiogenic shock. And these don't necessarily reflect the way that an echo is going to guide you through an approach to shock. And the other thing is that more often than not, patients in our units will have multifactorial shock, right? You can have a patient who has COVID, ARDS, and might be in septic shock. Maybe the patient has underlying aortic stenosis, and you might be worried that they're also having a pulmonary embolism. And so where ultrasound can help you is that sometimes it can help you straight up diagnose the cause of shock. And this is particularly true for basic echo, where you're going through the basic windows that we've mostly focused on for this entire year, where you put a probe on a patient and you get a subcostal view and you see that clearly the patient is in tamponade. Or you put on a probe and you see a blown RV and a clot in transit, and you know that you have a PE. And that's really nice. It's not so common, right? As many of us probably feel and are familiar with, it's not so common that you put on a probe and you've gone from undifferentiated shock to a diagnosis and you know exactly what your next step is. What I think happens more frequently is you have multifactorial shock, and using the echo probe can help you identify the most hemodynamically significant component of the shock that could perhaps guide your management. So you can decide that, you know, yes, maybe this patient has a component of septic shock, but I think that like this RV failure is most likely due to a PE, and we're going to sort of focus our next steps on that. Maybe get a CTA, maybe empirically treat, maybe look for a DVT, so you could treat that instead of having to look for the PE. And I think that's also where learning some of the advanced skills will become more helpful, because the basic skills that we've focused on for most of this year are primarily qualitative, right? RV big or poor or small, function good or function bad. Whereas in advanced echo, you're able to use more quantitative measures to figure out specifically how to quantify some of these deficiencies, which can then help you further identify which one is most hemodynamically significant. In the basic approach, you know, we've highlighted that there are 5 key views, but the truth is that there are there's an infinite number of views, because very often, especially for some of our fellows who through the year we've been putting the probes on the patients and really doing this at the bedside, very often you have to work with what you're given, and based on where the patient's bandages might be or volume status and the windows that you're getting, you might sometimes get what we would call an off-axis view. And while sometimes you say, well, if it's an off-axis view, you can't interpret it, as you become more familiar with what you're seeing and all the different possibilities, you can start to make interpretations and judgments off of these off-axis views, as long as you understand what you're seeing and what you're not seeing. And because of this, basic echo usually guides diagnosis and major management when you find these major things. And these are important skills to have, right? We have to be able to find a pericardial effusion that's causing tamponade. We have to be able to find a completely newly acutely blown RV, right? And so there's nothing wrong with having that skill set. But when you're, and it's important, it's important to have that skill set. At the same time, if you are interested in taking it to the next level, then at the advanced level, you're able to sort of guide more complex management, choosing your pressors and inotropes, maybe identifying a dynamic LVOT obstruction, which will completely change your management. And so for that reason, also basic echo is important, but has limited applications, whereas advanced echo has broader applications especially when you're starting to apply it to diastology, native and prosthetic valve disease, pericardial disease, or ECMO and patients on MCS. And I'm not going to go through this image in particular. You can see if you're interested, you can go find the original paper, but this is also sort of a pretty clear outline of the different things that basic versus advanced critical care echo can do for you, right? Your LV function, is there severe LV systolic function, or can I look at the diastolic filling pressures and see if those are too high and maybe this patient needs to be diuresed? Is the RV size large and the function terrible, or can you specifically quantify your RVSP, and so on and so forth? And we've taken the next step in some of our lectures also throughout the year by getting RVSP, VTI, talking about volume status. There's obviously a lot more to it. So taking that all in mind, my approach to shock is not to necessarily try to figure out which one of these buckets your patient is in, because the echo findings can be similar and different within and across some of these categories. And if you go and look for some echo algorithms out there for how to take your echo and use an algorithmic approach for assessing undifferentiated shock, you could find some, like some of these examples that I have here. The challenge with these algorithms is that they don't really guide how you should physically go through an approach with your patient, because the idea that you should first perhaps rule out LV systolic dysfunction, which requires looking at the LV for multiple views, and then if no, then thinking about LV volume overload and now going back to some of those views that you were already in to now take a closer look at LV volume, is obviously going to be repetitive and redundant, right? So what you really need is to understand all the things that you're seeing on an echo as you go through each window one by one. And so therefore my approach to undifferentiated shock on echo is actually quite intuitive and not rocket science, but I'll just share it, which is you first have to advance through all your windows methodically, right? So we spent a lot of this year going through all the basic 5 windows that you might be seeing. You go from your parasternal long axis, your parasternal short, et cetera. We'll review them briefly in just a moment. You have to advance through all your windows methodically. And within each window, you have to track findings that support various diagnoses. You can be in your parasternal long axis and say, okay, the LV function doesn't look so great. The RVOT looks like it's actually very large. So I'm not sure, is this going to be biventricular dysfunction? Is the LV function really falsely looking poor, but it's going to look better in another view, and the RV is going to be the problem? Do your valves look normal? And at each view, as you progress through, you start ticking off and ticking on different things that you think are more and are less likely. And then when you finish getting all those findings, you finish going through all your 5 basic windows, you can summarize your findings and reach a working diagnosis. And you say, based on these multiple views, I think the most likely cause of shock in this patient is X. And there might still be other things that you've seen in other views that maybe you weren't able to corroborate that you think are still potentially on the differential. But by going through all the windows and knowing as you go through them all the things to look for, which is the whole purpose of this entire year's lectures, you'll be able to come up with hopefully what you think is the most likely cause of shock. And then step 4 is not to forget the rest of your your extra cardiac assessment, your pulmonary, your thoracic ultrasound can particularly, and your lower extremity vascular ultrasound can particularly inform your differential diagnosis of shock, and we'll see that in some of our cases. And then what the most important things to do are now to make management decisions. Now you act. You have a patient who's in undifferentiated shock. You look at your echo, you have a couple of possibilities based on what you've seen, and obviously incorporating some of the other information. Echo is not the only way to manage. It's not the only data you should use in determining when a patient has shock, but obviously that's the topic of today's talk. Then you make a management decision based on what you've seen. And then the most important thing, and perhaps the most powerful component of POCUS, is that now you can reassess the patient after taking action, right? And this is the key. This is what makes POCUS different than formal comprehensive ultrasound. This is what makes it different than other forms of sort of assessing your cardiac function or your underlying etiology for shock. And so this is the opportunity, I think, for me to share why critical care ultrasound does not replace comprehensive echocardiography. Obviously, if you ever think that a patient needs a comprehensive echo, then you should still be getting a comprehensive echo, and you should never take your critical care focus to obviate the need for getting a comprehensive echo. But the way I think about this, and I think others have agreed or have not protested too strongly, is that comprehensive echo to me is an imaging tool. I think of it as like getting an MRI, but it's a good imaging tool for your heart. If you need to take a really good look at the aortic valve and quantify the specific gradient in the aortic valve area, you're much better off. You need a comprehensive echo. But a critical care echo is a monitoring tool, right? It's not as refined. It's not going to give you as detail. It's not as high res, so to speak, but it's something that you can use in real time to make a very focused assessment for your specific patient. It guides your immediate management decisions, and it can be reassessed. So it's not a continuous monitoring tool, it's an intermittent monitoring tool. But because of its ease of access, its accessibility, and the amount of information you can get, you can use an echo, make a management decision, choose an inotrope, choose a pressor, choose to diurese or give fluids, and then take your echo right back. And that's something you can't do with comprehensive echo. You're not going to get a comprehensive echo multiple times a day for your patient who's in undifferentiated shock. And so that's my overall approach to echo, and it's echo for undifferentiated shock, and it's not that complicated, right? It's really just knowing what you can see at all the views, taking it, out in an organized way, and making your assessment at the end. And so I'll very, very briefly fly through a review of the basic windows, just for those who haven't been doing this in a while and just want a quick refresher, and then hopefully we'll go through a couple of the clinical cases, and we can talk through what we're seeing. We can sort of do this in action, and then we'll be done. So as you recall, there are 4 or 5 basic windows. So you have your parasternal long axis view, where you're seeing the left atrium, the left ventricle, the LVOT, and the RVOT right here. And something I've mentioned in a previous lecture, I don't have a picture here, is where a modification, so if you're taking this to the intermediate level, a modification of the parasternal long axis view with just a simple adjustment can get you to the RV inflow view, and you can actually see the right atrium and the right ventricle and one view of tricuspid regurgitation. And then when you go to the next view, in the parasternal short axis view, there are actually 4 different pretty well-defined levels in which you can assess the heart. There's the aortic valve level, where you get the aortic valve, the left atrium, and the right atrium, interatrial septum right here. And this is actually the RVOT, and sometimes you can see the pulmonic valve right here. Then you go down one level and you're at the mitral valve level, and you can see the mitral valve, and you can see the papillary muscles one level below that, and you can see the apex of the heart at the apical level as well. And a modification of this view, also not shown in these simplified images, is the RV outflow view, where if you didn't get a really good view of the pulmonic valve and the RVOT and the parasternal short axis at the aortic valve level, with a simple modification and adjustment, you can really open that up, and you can actually see the right and left main stem of the right and left main pulmonary arteries. Sometimes you can even see a clot that's sitting there in a patient with a massive PE. And then you have the apical 4-chamber view, which is one of the best views for assessing RV function. You can see the left ventricle and the right ventricle, the left atrium and the right atrium. With a simple adjustment, you can get the 5-chamber view, where you look at the aorta as well. This hopefully is mostly a review. Then you have the subcostal 4-chamber view. This is one of the best views for cardiac tamponade. It's less helpful when you're looking at size of different ventricles or atria, but you're able to see both atria, both ventricles. If there is a circumferential pericardial effusion, you would be able to see that as well. And one thing, I don't know if we mentioned one of our lectures, something that I've shown at the bedside to a lot of our fellows, is that sometimes when you can't get a parasternal short axis view, often because the patient, if they're in the unit or if they're in the MICU, are going to be, perhaps a COPD patient or a patient with a lot of fluid and poor windows, you can get a subcostal short axis view. So with a modification, you're actually able to get all these views, the aortic valve, mitral valve, papillary muscle, almost the same exact views that you expect to get on the chest with the parasternal short axis, you can actually get in a patient by sort of going at their subcostal view by flipping the probe and trying to get a short axis in that regard. That's also something best taught at the bedside. And then the 5th view, the 5th window, of course, is the IVC, which you take with a grain of salt when you're thinking about your fluid assessments, as we've discussed in detail, but sometimes can be quite helpful. And then not a specific view for the echo, but not forgetting the extra cardiac assessment, particularly thoracic ultrasonography and a lower extremity DVT. So now we're going to take all that and go through some cases. We have a lot of time. I don't think we're going to take the entire hour today, so we have some time to really discuss and dive in. So I'm going to start with one case and maybe pick on some people. But here we have case number 1 is a patient who is a 69-year-old woman with an unknown past medical history who is presenting with lethargy, fatigue, shortness of breath after 5 days of feeling unwell. Has maybe some chest pain, nausea, vomiting, and diarrhea, subjective fevers at home, afebrile, tachycardic, hypotensive, has a bit of an oxygen requirement, and on exam is altered, has diminished breath sounds bilaterally, no murmurs, no abdominal pain, 1+ lower extremity edema, extremities are normal temperature, has a little bit of a white count, a creatinine bump presumably, we don't have a baseline, lactate elevated, elevated BNP and trope, and you have a poor quality x-ray, but no obvious infiltrates. And so my question for the room here is, what is your differential diagnosis for this patient? You could shout it out loud, you can type it in the chat. What are some conditions that you're thinking of, at least for this patient's hypotension with lactate, where you're worried that they're going into some sort of shock? Got to vote for sepsis, thank you.
Jenna, we say a PE.
Love it. PE, so we have some chest pain, we've got an oxygen requirement, shortness of breath, certainly on the differential. What else is on our differential for this patient's as yet undifferentiated shock?
Cardiogenic source.
Also, yep. Can't really see anything. We have a BNP that's elevated, diminished breath sounds, lower extremity edema. We don't have this patient. We have no known past medical history. So this patient could be Brian Rosenberg. Undifferentiated shock could be anything. I think that sums it up, right? So here's could be anything, right? Septic shock. You have leukocytosis, you have a history, it sounds like infection, and this patient would get, fluids and pressors, antibiotics. Could be a pulmonary embolism, in which case you're going down a very different pathway, anticoagulation, depending on how severe it gets, you might be talking to the PERT team. Could it be a viral illness with septic shock? You have this oxygen requirement, cardiogenic shock, truly anything, right? This is a case that we see all the time, and it could be any of these things, right? So that's the whole purpose of this case, that we have a case of undifferentiated shock. So now we're going to go through some of these windows methodically and track our findings. So here is our parasternal lung axis view. What do we see?
The LV looks like it's hyperdynamic, or it's collapsing all the way.
Great, awesome. So what does that do to your differential right now?
More inclined to think there's a component of hypovolemia or distributive shock.
Yeah, exactly, right. So perfect. So yeah, so this is fairly representative of an actual ICU clip, right? This is the kind of the quality of the images that we've sometimes come to expect from some of our patients, but it does seem to be on axis. We're seeing both valves, the apex is sort of off camera, and the ventricles are kissing each other. So it seems like it's hypovolemic or hyperdynamic, right? The RV right now does not look particularly blown. If we were thinking about a PE, we might be less inclined right now to be thinking about that. And if we're thinking about cardiogenic shock, maybe not as much because we see good function. Of course, we could be fooled. We could be a little bit off axis here. We could be sort of grabbing the sides and foreshortening along one side. So we want to be careful before committing to this being, an EF of effectively 100%. But this is already starting to guide the way that we're thinking about this patient, right? So now you move on and you go to get a parasternal short axis view, and here you are at the apical level and maybe just below the papillary muscle level. And what does this confirm or refute or add or change? I know I didn't give you all the short axis views in this case. Good function, not good function? Is it still hyperdynamic?
It still looks hyperdynamic at this view, but we're at the apex, so we would expect it to be almost 100% EF here, wouldn't we?
Exactly, perfect. So yeah, so that's exactly right. If you're at the apex, right? The apex, even in patients with a poor EF, sometimes just as it contracts, it sort of obliterates the entire cavity. So it's hard to know exactly necessarily from here if this is still confirming your hyperdynamic state, or that you sort of hypothesized on the previous clip, or if we're just sort of at the apex, and in this apex right here, it's always going to, it's just the normal baseline sort of complete contractility. Now, it might look like in this view that you are, it does sort of get smaller. I'm going to, because you mentioned this, I'm going to put you in the hot seat for just a second. It does look like it gets smaller and gets larger. So does that mean that we're sort of moving up from the apex to the apical level and it's still 100%, or might there be something other explanation for why it gets smaller and larger?
I thought that was because of the motion of the patient.
Yeah, so that's one possibility, right? The patient could be, as a patient's breathing, the patient could sort of like the apex could be coming in and out of view. If that were the case, then it could be that the patient's apical level, not the apex itself, but the apical level or something closer to the papillary muscle level might be sliding into your view. And then if you still think that it's an 100% EF, then it might actually corroborate some of the hyperdynamic function. This clip, which is not my own, you can notice from the side over here that whoever's doing this is actually, these dots tell you the distance. So you can see that as they're moving, whoever's doing this is actually adjusting their depth while they're getting this image. So you're actually just sort of almost zooming into, so to speak, in the same apex. So it's also probably still the apex, just they're decreasing their depth to get it, to take up more of the screen. So it's a little bit of a tricky shot. But yeah, so this is an apical view that sort of maybe gives you more information, but I appreciate the hesitation in overcalling anything from this view. And I think that's important because sometimes, to point this out also, because I'm not giving all the short axis views, and because very often you won't get them, right? Sometimes this is all you'll get. And if you get just this clip, you could be inclined to say, okay, this patient's got normal LV function, let's move on, and not realize that, no, that's not true. And actually, if you were to be able to get the higher level views, you would realize that this patient actually perhaps has diminished LV systolic function. All right, so now we move on to our apical 4-chamber view. What does this do to our differential and our walkthrough for this patient? Any pulmonary fellows interested in chiming in also, helping Helen out? Got a, see a little chat here. Enlarged atria, okay. Very possible. Don't know for sure, could be. Enlarged atria generally, while they could be here, I'll say generally don't change my differential for acute undifferentiated shock because they're usually chronic. So it could help you inform, let's say, for example, if you found mitral stenosis and you don't know anything about this patient's past medical history, and then you see a large atria, it could help you, realize that, like, okay, this patient has sort of chronic condition going on. But that's a good find. All right, Helen, help us out. Take it home. Oh, we have another comment.
Oh, wait, someone said something.
Oh, poor squeeze. Okay. So this is I appreciate you saying that also. This is a really tough view because you get so much, as the LV is squeezing in systole, you're getting a lot of this granular artifact and almost like overgain. So it's really hard to say, because if this here, I can't pause this as a GIF, maybe next time I'll use clips. If this here is endocardium, then this could just be still like an underfilled left ventricle, and that's what I think is happening. And this heart is just completely contracting, right? If the endocardium is sort of here, and this is just like a papillary muscle waving around, then you could argue that perhaps this LV is not moving as much. But I think this is that's a perfect representation of how we need to get this from multiple views, where if you just saw this view, you could also have to be very careful about calling anything about LV function. But together with perhaps this, we can be more convinced maybe now that this is like an underfilled or hyperdynamic or both left ventricle. Oh, and then we have this here. What does this do for us? This is our IVC.
Just very collapsible.
Yeah, and probably thin. Any sense of how wide this I'm not measuring it for you. Any sense of how wide this IVC might be? 1 centimeter, 2 centimeters, or less than 1 or more than 2?
Would say less than 1 probably.
Yeah. So I think you're right. But I also wanted to point out that sometimes when you get the IVC, it's in the subcostal view, right? And sometimes that requires a tremendous amount of depth. And then the deeper you go, the smaller everything looks. So you could get deceived with IVC size. The best way to do this is to look, this patient is at 19 centimeters of depth. And then all these dots, if you count them, it's probably going to be 19. So each of these is 1 centimeter. So one thing you could do if you don't have a caliper here is you could sort of look at this, that's 1 centimeter. And maybe this is what you did, Leonardo. I completely agree with you. This looks thinner, thinner than this. So it's less than 1 centimeter, so small and collapsible. And while I dislike the IVC most of the time for most reasons, this at least will help you think what in this case?
He has not a lot of preload at this current time. Yeah, he's
underfilled. So like maybe low volume, or again, it could just be like a hyperdynamic heart that's sort of shoving that cardiac output so quickly. But more likely perhaps makes you think something like hypovolemic. And so when you're looking, so here we have this patient who came with undifferentiated shock. Our initial differential diagnosis included, to Dr. Rosenberg, everything, which I fully agree with. And then you end up going through this echo and you have hyperdynamic biventricular function. So we've pretty quickly ruled out cardiogenic shock. We had normal RV function, right? We didn't see, I didn't go back to comment on this, right? But in the apical 4-chamber view, the RV was not larger than the LV. There was a good TAPSE. Let me just sort of go back and point that out here, right? So here you have an RV that's sort of compressing entirely. It's not enlarged over the LV. The TAPSE here, which we didn't measure quantitatively, but you could see that the annulus is moving up and down, right? So we probably don't have a PE. We have a collapsed IVC and underfilled ventricles. This is most likely hypovolemic shock, possibly septic shock, right? Or both, right? And so what are we going to do? Well, we're going to give this patient fluids. We're probably going to give them antibiotics. But then again, the most important thing we could do is reassess their response to 1 to 2 liters of fluid. We don't have to give them 6 liters of fluid and then like look at their blood pressure. You can literally go give them a unit, give them a liter of crystalloid, and then go take another check with an echo. What about the O2 requirement? What about the trope and the BNP? What about the lower extremity edema, right? These aren't board example cases. And I think that's the point too, is that patients in our unit very often have this, right? They have a mixed picture and there's tremendous amounts of data. And what we have to do obviously in the unit is use our best judgment to choose which are the most important data that guide the diagnosis and management, which are distractors, perhaps with other explanations. And the echo is one powerful tool that can help you make some of these determinations. Again, the echo itself will often not give you the answer on its own, but it'll help you figure out where you're going to be focusing your management. Now, we sort of mentioned how this could be hypovolemic or septic or both. So how can we, or hyperdynamic, I should say, maybe a high output cardiac state, how can you further tease apart hypovolemic from septic shock? Anyone?
Warm versus cold extremities.
Okay, like that, exactly. That's a fair point. Physical exam skill. I was going for echo things too, but yes, that's another very fair point, right? So in a septic patient, you're going to have systemic vasodilation. They'll be warm. If a patient's hypovolemic, then they'll probably be hypoperfusing. So that's a great point. And you have cool extremities. You might be having more, your lactate will be difficult to determine. And then we have the answer that I was also hoping people would say, because it's an echo lecture that we had, which is using your cardiac output via VTI. Again, if you could be septic and hypovolemic, in which case you can't tease them apart because you'll get all the findings for hypovolemic on echo. But if you're septic with hyperdynamic heart with a high output high cardiac output state, then using your cardiac output to assess stroke volume via VTI. So if you go back to our cardiac output lecture, can give you that answer. If you have a normal or high stroke volume, this is hyperdynamic. Maybe you don't need to give this patient fluids necessarily, right? If this is a patient who's hypovolemic, then you certainly do. And if you have a really low stroke volume, it can guide your management as well. And so a VTI is not a basic skill. We've talked about it in our course because I think it's one of the most important advanced skills. So over time, I think it's going to become an expectation that everyone sort of has the ability to perform. But right for now, it's still counted as an advanced skill, but very powerful in guiding, for example, something like this specific situation. If this patient is septic, how can we further assess whether we want to give this patient more fluids or, missing an R, their pressors? Some echo-based skills that can help you guide your management. So we had a whole lecture on fluid responsiveness, right? So how can you use echo to help guide whether or not this patient's fluid responsive? Although I also said that echo is probably not the best way to do it. Thank you. Yep, but passive leg raise and VTI would probably be the best way with an echo if you did. And then the other thing, though, of course, is not to remember whenever you're talking about fluid responsiveness is also assessing if the patient is fluid tolerant. And one of the ways to figure that out, certainly not the best way, is to use a thoracic ultrasound. But really, you're right. You want to make sure that by giving fluids, it's not going to just flood the patient's lungs and then create a different problem. But if you can use your echo to both guide your ultrasound probe to guide whether this patient is fluid responsive, is fluid tolerant, needs fluids at all, a lot of power that you can get very quickly with a couple of minutes with an echo probe at the bedside. All right, so case number 2 of 4. So very similar case. This is a 69-year-old woman with an unknown past medical history with lethargy, fatigue, and shortness of breath after 5 days of feeling unwell with some chest pain, nausea, vomiting, and diarrhea. Same vitals, same exam. X-rays poor quality, maybe there's a right-sided infiltrate. So I'm not going to make everyone repeat this because this is the same undifferentiated shock, and that's sort of the point, right? That I'm showing you how the same clinical presentation with the same clinical data can give you the same differential diagnosis of undifferentiated shock. Maybe this patient with a possible infiltrate in the lungs, maybe you're adding pneumonia with septic shock to your differential, but this is what you get. So time to scan, and we're going to go through these windows methodically again. So this is one of my own echoes, so I am guilty. Anyone willing to comment on what we see, what view this is? And well, I wrote that as the parasternal lung axis. What are some of your thoughts about this window, this view, and what we're seeing?
Hey, John, it's really hard to make out a good EFs like the interventricular septum. It's really hard to kind of discern that in a way. We're in the parasternal lung axis view, and then just you're not really getting a good IVS like in terms of the septum, whether it's moving appropriately, whether it's thickening. It's hard to say.
Yeah. What makes it so hard? I agree with you.
I think it's the interventricular. There's a lot of like, it's very grainy. That's one. It's you can't really make out the at least the LV free wall as well. Very well to see if it's thickening also, and you can't really get a good E point as well. So like all those things, it's very hard to really kind of tell if this is a good EF or a bad one.
Yeah, I agree with you.
Yeah.
Helen in the chat is pointing out a pericardial effusion, which people also forget that we can sometimes see in a parasternal lung. And we got a comment in the chat from Dr. Rosenberg, off-axis parasternal, but really dilated proximal aorta to sinuses, seems pretty cardiac. A pericardial effusion, need to rule out dissection. I love that. Okay, so Brian, I think you're maybe picking up on this over here. So you're seeing that like this, if I'm not mistaken, maybe you're seeing some of this line that can look like an aortic dissection, and this here is probably just part of the bulb. I think part of right. So I think part of the Leonardo also why it's so difficult to comment on this is that this is off axis, right? You can't really make a statement about like the EF right here. This is a classic situation. I will like to pretend, I don't remember the exact case now, but that, I mean, my exact moment at the bedside, I'd like to pretend that this was the best parasternal I could get, meaning that, and this is sort of a representation of what I was saying earlier, which is that sometimes you have to work with what you've got. And part of working with this one is that you can't really make a comment on EF because you're certainly off axis and missing a lot of the, and missing sort of what the LV systolic function would do. If I was worried about the right heart, maybe I feel comfortable saying that like this RV doesn't look super large from this view and is like contracting nicely in the RVOT. But the caveat there, and that's the same caveat that I'm going to raise with Brian's point about like assessing the sides of the aorta, is that once we're off axis, you can't necessarily use your rule of thirds if that's how you're deciding that the aorta is large. If you're comparing to the RVOT and the LA, well, if you're off axis, you can be cutting one off smaller and one bigger. As far as whether or not this is an aortic dissection, that's a really important point and a good finding. in this case, because one of the things that you would expect to see in an aortic dissection is that this would sort of be flapping up and down with systole. And systole, sort of those dissections sometimes would tend to get smaller or bigger depending on which side is real and which side is the real flap and which side is the intimal flap. This line is actually not moving that much. It's kind of steady, and I suspect it's a reverberation artifact of something, let's say, up here. But definitely something we're going to want to take a closer look at other views if we have that opportunity. So lots of questions on this view, right? We don't know much about LV function. We can't really say much from this view. We have a pericardial effusion. Let's look at the next. So these are parasternal short axis views, and these, I apologize for a couple of things. Number one, I took these without, like, I should have just increased my depth. These would have been such beautiful pictures if only I had increased my depth. And I also left this this continuous wave Doppler line on, which has no meaning in these clips. So forgive me for that. And just try to look past that and comment on what we're seeing at these parasternal short axis views, if anybody's willing to say.
Jonah, for that first image on the left, I'm most struck by how much the RV outflow is moving, like how floppy it seems. I can't describe what it means, but it looks abnormal.
Okay, so it looks like that's just a little bit rigorous over here in the,
Yeah.
on the RV side, the RVOT, perhaps. Yes, could be. It could be normal, I'll tell you, you know, because you're sort of getting the free wall as it sort of does that bellows inward. So this could be a sign of like a rigorous RV, but we'll, yeah, we'll see. I see we have a comment in the chat. Aortic valve not opening as much as I would expect. I agree, Saris. You know, that this aortic valve, you know, you'd usually expect it to open up much more cleanly, certainly like this, and it seems to be an on-axis clip. So why is that aortic valve not opening so much? Does this patient have some aortic stenosis we didn't know about? It does look pretty thick around the rims, a little calcified. So that's an interesting point. Agree. You can see the pulmonic valve in this view. That's kind of nice. I'll move on to some of these if anyone wants to comment. This is the mitral valve level. This is going to be the papillary muscle level. Any thoughts about LV function here? Or other findings? RV function, RV size, septum. Sometimes you can look at clips like these and think like you're so used to, especially if I put this case right after a hyperdynamic case, you can look at these and think that this is, you know, reduced systolic function. But I agree with the comment in the chat that the LV function is actually okay looking, right? This is all the, so if you put your finger in the center here, all the walls are sort of thickening and moving towards your finger. So that's a sign that perhaps some eyeball method of ruling out maybe a regional wall motion abnormality. The LV is thickening. The chamber is getting smaller. It's not, I wouldn't call this hyperdynamic, right? But this could be totally normal LV function. What else do we have? Let's see. Apical 4-chamber view. I'm telling you that the IVC look normal. Anything to say about this apical 4-chamber view? I'm going to take the silence to mean that there's not much to say, and I kind of agree with that too, right? We kind of have a normal looking LV. We can't comment too much on the RV because there's shadowing over the free wall. Although, you know, you get a whiff of the fact that it probably has a good bellows effect, and maybe there's a good TAPSE. We can't really tell. I don't know if anybody else has anything else to say. I don't have anything particularly good. We're not seeing like a huge effusion anymore, which we saw from other views. So if you had this patient with undifferentiated shock and you wanted to tie together all your echo clips, you might say that this patient has seemingly normal biventricular function, so it's probably not cardiogenic. Normal RV without a pericardial effusion, or I should say a small pericardial effusion. So probably not a PE or cor pulmonale or another form of obstructive shock. Normal RVC and ventricular diastolic size, so it's unlikely hypovolemic shock. So you might be scratching your head right now, which I think is the right response. And the truth is that I want to take a moment, pause from this case and share that this is a very normal appearing echo and shock. And this happens all the time, right? I would say probably 80% of the time, your echo is not really going to necessarily help you figure out your cause of undifferentiated shock. When you find some great finding that then can guide your next steps, that's amazing. And because it's so easy and free and risk-free, you know, we should be doing this all the time, but I'm not trying to tell everyone that every case of undifferentiated shock is going to be solved with the echo. And this is a good case where it seems like you'll get something like this. And that usually to me suggests that it's non-obstructive, non-cardiogenic, unless they're already on pressors and inotropes, which could be masking the cardiogenic shock, but you would probably have known that at this point. I think it's usually due to a combination of hypovolemia, sepsis, vasodilation, sedation, right? Many different things that can tie into why a patient is in shock that doesn't have some immediately treatable finding that you're going to see on echo. But that's not the case this time. So this time we're going to take a look at the lungs too, and I'll share with you that this was the right middle lung zone and this was everywhere else. What are we seeing here? And what are we seeing everywhere else? And what does that suggest?
She has B lines on the right lung and seems like a localized area, and then she has A lines everywhere else, so she seems well aerated except for one spot in her right lung, which is consistent with the x-ray that you described, saying that there's an infiltrate.
It is. Thank you. So what does that do for you? What's your differential now, or how does that adjust the way you're thinking? Not just you, anyone else. I don't want to punish you for speaking up and sharing the correct point. You're welcome to, but also if we have focal B lines, probably pneumonia. I agree. That's probably usually the case. Now, we're going to do the thing that we forgot to do, which is put some color on your valves, which you should never forget to do, right? And this patient had some mitral regurgitation. Now, it might not look like so much on this parasternal lung axis view, and partially that's because this is not the best view for you to be looking at mitral regurgitation. Your MR, your color Doppler, as we've talked about in several of our other lectures, is best when it's perpendicular or parallel. I always say perpendicular, but I mean parallel to the probe, right? So if you're as in the apical 4-chamber view, you'll get a much better view. The MR is almost always going to be underestimated or underrepresented in the parasternal lung axis view, and still this patient has a decent MR jet here. And if you looked in their apical 4-chamber view, this is, all right, this is not mine, but we'll call this a representative, right? This patient has a raging MR, which would have looked like a normal echo without color. Maybe explains Ceres's observation that the aortic valve wasn't opening up so much because all the flow is going backwards, right? But overall does explain why you would have a right middle lobe infiltrate and some sort of edema in the right lung. But if you don't put color on your echo, you're never going to find MR. And MR is probably one of the most important missed acute findings that will significantly change your management, right? It's not that common, but it happens and we see it all the time. And if this patient has new moderate to severe MR, you're calling the heart center, you're calling cardiac surgery, you're thinking about urgent mechanical circulatory support. Acutely, you might be thinking about afterload reduction. You're going to be potentially getting an ischemia evaluation, right? Your day has completely changed the moment you put color on this patient. But if you don't, you get you get an unremarkable echo that you see in most of our patients who have some sort of like shock that we can't otherwise explain. And so just a shout out for an LV, to look back at the LV systolic function lecture, the thoracic ultrasound lectures. I'm hoping that at some point, maybe next year, we'll do a lecture on valvular disease on POCUS. But for now, you don't even need to have an in-depth view of valvular disease to be able to recognize severe raging MR and to know that you should be calling the appropriate services. So we have 2 more cases in 10 minutes. I'm going to go through them a little bit more quickly. Surprise, surprise, it's the same exact case, undifferentiated shock. This time, anything jumping out?
big RV that's collapsed seems almost like it's compressing the left heart.
Yeah, huge RV. And I'm hoping one of my fellows, one of the pulmonary fellows are going to call this the RV takeover sign, because I'm really trying to get that to become a thing where you do the parasternal long axis view and you get the RV instead of everything else. We've got a huge RV and it's compressing the LV. And here you've got flattening probably throughout the respiratory cycle. And you've got a huge RV over here also. And your TAPC is actually maybe moving, but you're not getting the bellows effect here, right? The RV is not really compressing that well. And immediately we're thinking, okay, this is your RV, right? I don't, the problem is that that's not the end of the story, right? Your RV failure, acute RV failure itself has quite a differential diagnosis, right? So it could be a pulmonary embolism. Anything on this echo that might tell you that this is or is not a pulmonary embolism? It's not the greatest quality image. But
Something seems to be coming in and out of the RA into the RV.
Yeah, you have this something spinning around in here, and then occasionally you're seeing it here. You've got a clot in transit. And if you have acute RV failure and a clot in transit, you're done. No CTA, just go. You're depending on how severe it is, you're either just treating with you're either anticoagulating or you're calling the PERT team or anything in between. More often than not, you have acute RV failure, you're not going to see a clot in transit. So then you're stuck with the rest of your differential, cor pulmonale, decompensated pH. Again, in a patient who you don't know their past medical history, could this just be obstructed from an acute pneumothorax? How do you tease all these apart? Besides all the other things, right? You get an X-ray. If you happen to know that they have pH, that's helpful. But if you don't know, that might not be. You probably know that they have cor pulmonale or ARDS, at least if you saw that on the X-ray. It's also another plug for using your lung ultrasound, although I'm not suggesting that despite the new ARDS guidelines that lung ultrasound is the best way to diagnose ARDS. But if you don't know about a history of pH, but you do know how to measure an RVSP and you find an RVSP that's above 60, 70, 80, then you know that that's not going to be acute. Saris also mentions RV wall thickness for chronic pH. Absolutely, right? Something that's a little bit less rigorous data for that. But if you have a 5 millimeter, 1 centimeter RV free wall, that could be a sign of chronic pressure overload. If you got your RVSP again and had really high pressures that were above 60, usually you can't generate that acutely without having chronic pH. If you had a clot in transit or a DVT, if you did your lower extremity ultrasound, you can identify a clot and increase your likelihood for PE as well. So this is a patient who had normal LV function, a severely dilated RV with septal flattening and a clot in transit. So no pericardial effusion, normal valves, dilated IVC. So this was almost certainly a PE. But again, if it wasn't a PE, you still have so many other powerful tools with your echo and beyond your echo to sort of help differentiate the etiology of this patient's acute RV failure. And so some helpful lectures when you're thinking about RV failure, to, keeping in mind that RV failure alone is not enough of a diagnosis. Acute RV failure has a differential. You're going to have right heart function. If you look at the right heart function lecture, RVSP, DVT assessment, thoracic, these are all going to be helpful. So I'm not going to review this. You can find these on YouTube. This is just to remind you that it's there. This is the summary slide from our RV function lecture, telling you all the different things you could see about the RV from all the different views. This is the summary slide from our RVSP lecture, showing you the 3 different common windows where you can sort of assess RVSP and get an RV function. And of course, we've had thoracic ultrasound and DVT lectures that can help you remember and help avoid some of the pitfalls in using this wrongly and using it correctly. And then finally, our last case of undifferentiated shock that I'll also move through a little bit quickly. Anyone want to comment on another one of my poor windows? It's not great.
Tara thinks the LV function looks poor.
Thank you. I agree with Tara. And
commenting quietly.
You've been commenting quietly. It's on mute. So you have some squeeze here at the apex, and you have to be very careful because there's shadowing here. And this is but it doesn't look to me like there's much movement here. It looks almost like there's some passive movement here. I'm not going to I would never make a call on this view alone, but this is going to really focus my attention in the coming clips. And I apologize again for overdoing my depth. This was my 30th echo, so it shows you that even at echo 30, I didn't have the hang. I wasn't routinely knowing to decrease my depth. All right, so let's put color. We now know we're never going to forget color. Anything exciting here? I don't think so. I'm going to move on. And here are some other views of our LV. Tara, do you still think that the LV function is poor? Or do you want to revisit that? Or have you confirmed or denied your suspicion?
I think mostly confirms.
Yeah, I mean, how does the function, let's just look at this one. What is the function? How does the function appear to you?
Yeah, I'm trying to see if like there's any focal wall motion abnormalities that I see. Maybe like the septum's not moving in as nicely as the other walls, but none of them seem to be moving in that well, or thickening that well.
I agree. And do you think that the function at the squeeze of the mitral level is sort of equal to this papillary muscle level, or better or worse, or not meaningfully different?
I wouldn't like meaningfully call it different. Maybe it's a little better.
Yeah, I agree. I wouldn't say anything meaningful. The truth is that at the annulus, my experience has been that you don't see as much squeeze. I think it's just because of the strength of the annulus, right? The mitral valve itself at the annulus is not squeezing. And despite that, this seems to actually, maybe not meaningfully, we think about it, but seems to be a little bit more squeezing a little bit more rigorously than here. And here, if you put your, again, I appreciate that you're looking for wall motion abnormalities. If you put your finger, again, like I'm putting the mouse right in the center, is it sort of biting in at all sides equally as best you could tell? I think so, right? If there's shadowing here, there's shadowing here, but I do think so. So it doesn't make me think that there's necessarily significant regional wall motion abnormalities, but maybe just diffusely poor LV function. And here we have an off-axis LV apical four-chamber view, and also just a poor window, not deep enough, foreshortened for sure, right? The ATR completely cut off, best I could do. And again, I think maybe you have some sort of, this is what we might have been seeing at the base, right? Maybe you have some, we saw this in the parasternal long, we saw this maybe at the mitral valve level and parasternal short, where there's some squeezing activity at the top here. And then just out here, it's almost rounding out. Again, I don't want to say anything because of this poor shadowing and windowing. When you put all these windows together, it starts to tell a story where this patient probably does not have good LV function, and maybe it's better at the base than the apex. And when you put some color on here also, I'll just share that it wasn't remarkable. I just sort of put it here because I just gave a whole lecture on not forgetting your color. And then you get a subcostal four-chamber view. What do you think about your LV function? RV function? So there might be some silence here because it almost looks like suddenly you have a good LV function. And I think this is just an exercise in restraint in calling function with a subcostal view where you're almost always going to be foreshortened. So this RV looks huge and the LV looks narrow. And I would be really concerned about calling this normal LV function just based on this, because I think you're probably foreshortened. The TAPSE, and which, there's another term that's escaping me for like sort of measuring the TAPSE sort of in the subcostal view, but it looks like you've got rigorous RV function. But if you just look at the LV and ignore that it looks like it has a good EF, because again, I think you're foreshortened, look at how much you think the muscle might be thickening during systole. Right? Not that much movement. Don't get confused by the papillary muscles that are sort of coming into view there. Right? The muscle's moving, but it's not really thickening very much. And so if you didn't want to call normal LV function based on all your other views, you are not obligated to based on this view. And here we have what looks like a pretty wide IVC. And so if you put these all together, I think you might say that you have a mildly enlarged, maybe more than mildly enlarged LV with impaired systolic function, perhaps particularly at the apex with better function at the base and normal RV size and function without pericardial effusion. So this is probably a patient, if they're in undifferentiated shock and you don't think that they have underlying reduced EF, they're probably in new cardiogenic shock, maybe a stress cardiomyopathy, maybe not. You'll have to decide clinically whether or not this patient needs an ischemic evaluation or some other evaluation, if they have myocarditis or some other cause of acute cardiogenic shock. But you're going to be managing this as probably an acute cardiogenic shock. And how do you tease apart acute from chronic heart failure? Well, I sort of mentioned, I mean, it's nice if you have an old echo. If you don't, you might want to look for other signs like dilated atria, thickness. You can also, again, look at your, the other thing to look for is your VTI for cardiac output, because if this is a patient who has a compensated decreased EF, then their stroke out volume and cardiac output should be normal, and their shock might be from something else. If their stroke volume is terrible, then it's probably or possibly also still related to their heart failure. So lots of things to think about. Hopefully this has demonstrated for us how using the echo will guide and narrow your differential, how the more skills you have with your echo, the more it can do for you, but also how the echo is not the only solution for most of these problems. And so just to conclude, this is again our summary slide for the way that we're methodically, without any rocket science, sort of using the echo to assess undifferentiated shock. We approach each window with the differential in mind, knowing what to look for. We incorporate other organ ultrasound as guided by the clinical picture, and we have to know our own limitations. And then the more we do this, the better we get at it. We have to believe. I'm very sad that Ted Lasso has ended. And I am remaining here for any questions. Thank you.